We are live.
So welcome everyone once again to this unique series of One Problem, Many Solutions, which is coordinated by none other than Dr. Harshul Tak, who's the course director for this series. And in this series, in the webinar today, we have options for the scleral fixated IOLs, glued IOLs, etc., which are implanted when an intact posterior capsule is not there. And I'm sure this is going to be very useful. This is one of the modules of the many modules which are there in this. And I think the best part is that there is going to be a certification in this. We have a galaxy of speakers uh, who are going to be looking at the various techniques. And over to you, Harshul, for deliberations now. And you can always download your certificate once the module is complete entirely. So thank you so much, Harshul, for coordinating this.
Thank you so much, Namrata ma'am, for giving this wonderful opportunity. And today we have, as ma'am said, module 12 of One Problem, Many Solution. And today we'll be discussing about IOL choices in cases of no capsular support. Today we have amazing speakers lined up. We have Dr. Divakant Mishra, who is a prolific VR surgeon from Lucknow. Welcome, Dr. Divakant, who will be also moderating the session as President of Young Ophthalmology Society of India. And we have Dr. Navian, uh, who we all know has invented CMT Flex lens for in cases like this from Chennai. Welcome, Dr. Navian. We have Dr. Minu Mathin from Trivandrum, Kerala, a prolific surgeon, a great teacher, and he'll be speaking about use of glued IOL in such situations. We have Dr. Rajesh Fogla, another prolific surgeon, corneal and refractive surgeon, who is a great teacher and a great friend. Thank you so much, Dr. Rajesh, for accepting our invitations. We will be speaking on Yamini's technique of scleral IOL fixation. And we have Dr. Renuka, who will be speaking on iris clear lenses. And we'd like to thank expert panel for today evening, none other than Dr. Priya Narang from Ahmedabad, Gujarat, who has a lot of innovations to her credit and who has won numerous international and national awards for her innovative techniques, and who has done immense work on glued IOL and SFT and all those techniques. Welcome, Dr. Priya. And we have Dr. Srinivas Joshi, who is a prolific VR surgeon from Joshi Eye Institute, Hubli. We all know he is currently ARC member also, a great friend and a great surgeon as an expert panel today. Thank you so much, Dr. Srinivas Joshi, for joining. And now I hand over to Dr. Shalini Mohan to invite first speaker.
Thank you so much, Dr. Harshul and Dr. Namrata Madam for having me here. This today is going to be an amazing, interesting topic because many a times we get to see these kind of patients where there is no capsular support. And then today we have wonderful expert panel who will be guiding us at how to go about those particular cases. So the first talk is by Dr. Devakant. We know he is a wonderful VR surgeon and president of UC, lead surgeon of Swarn Jyoti Eye Hospital. And I invite him for his talk on Beyond the Pupil, scleral fixated IOL in anaerobic eye.
So just for everybody's information, for this course, we have 1,090 registrants, and most of them, in fact, watch it later on. But this is the total number that we have for this FACO course. And again, kudos to Dr. Harshul Tak for doing this almost single-handedly. And thank you so much for doing it. Yes.
Thank you, ma'am.
Thank you so much, ma'am. I'll just take 2 minutes to introduce Dr. Shalini, ma'am, as well. She is the professor and in the Department of Ophthalmology, GSV Medical College. Very dynamic leader. She has been a gold medalist during her studies and has a lot of publications and unique awards like the BC Roy Gold Medal, Mohanlal Gold Medal, and she has some unique innovations to her credit as well. So thank you, ma'am, for co-moderating the session with me.
Thank you so much.
Thank you, Namrata ma'am and Harshul sir, for this wonderful opportunity. So, I will be talking about scleral fixated IOLs. So, I thought I'll present something a bit more than this. So, I have done a couple of these scleral fixated IOLs in the aniridic eyes. So, I'll present this video. I hope my slides are visible. So this was a young male who had undergone had a trauma and presented to us with an aphakic eye. So the biggest challenge that I faced initially in this surgery is that when I started doing the surgery, as I had made all the possible entry points, and when I took out the IOL, I realized that something very important was missing, which was the haptics. So both the haptics were missing in the lens. So then I had to abandon that surgery. I ordered the IOL again. The IOL came after say 2 weeks or something. But this time I had become a bit smarter. So I opened the IOL pack before it. Unfortunately, again, there was one haptic missing. We had gotten better, but still one haptic was missing. Finally, I was third time lucky and was able to get another IOL which had both the haptics in place. So that was the first learning that I had with these IOLs. So I went ahead. I had made the pockets and the tunnel before that, and of course, all my three ports are in place. So what I have done is that I've made two scleral pockets 180-degree apart, which were already marked before in the surgery. So I've not shown the marking of it. And I have used a 30 gauge needle to get my, so what I use is a 90 Prolene. So from one side, I've introduced that 30 gauge needle, which has helped in docking the Prolene needle. So I prefer the straight needle at both the ends. There are sutures where we get a curved needle at one end and a straight needle at the other end. We can do with that as well, but this is preferred. So with the help of a forceps, I'll grab one end of the needle from one side and bring it out adequately. Similarly, the other end of the needle is also docked and taken out. So now we have these two sutures inside. With the help of an instrument, usually I prefer my ILM forceps to grab and get it out. Now I'll, with the help of this, slowly from both the sides so that I have equal ends on both the sides, I have brought it out. This is the IOL, the aniridic IOL. It's a huge lens. I've cut these sutures in between. Now we have two ends which are there, and these IOLs have these eyelets in the haptic, and the one end of this is passed from this and tied. Now, a big challenge with these surgeries is manipulation of these sutures, and this has its learning curve. It becomes a bit confusing in the beginning, and you need to keep doing it while you get well versed with this. So after tying this, we have to, take care that the knot that comes to the outer aspect of the haptic, so that while pulling the IOL, it doesn't get decentered, or we don't have issues with that. So after tying this suture, I'll do it similarly on both the sides. Yeah. So the remaining part of the suture is cut from there. So now what I realized again that the optic of the IOL is pretty big, so I had to enlarge my tunnel, and you have to be very careful. We can cut the inadvertently cut the sutures as well while doing it. So now I was able to introduce the IOL. These lenses, another learning is this, these are very delicate, so you have to handle them very carefully. Otherwise, you will end up breaking one of the haptics. So with very soft hands, we have to extract the sutures from both the sides. Now we can see that it has fit really well, and we will tie the after cutting from both the ends these sutures, we'll tie them there. So these pockets that we have made, the knot, we have to make sure that it goes inside the pocket, because if it is not done so, or it is lying loosely outside, then it might cause erosion of the conjunctiva later on, and becomes a irritating point for the patient and difficult to manage. So after tying these knots, what we do is, this is how the knots are tied. Now, what I do is that I usually don't tie it completely on one end. I just take one pass, and after that, I complete the tying on the other end. So that helps in titrating the IOL, the position of the IOL. Now, I'll use a spatula to gently put the remaining part of the suture inside the pocket. So this is how this looks. It's well centered. This is first post-op day for this patient. So the lessons learned from this is, of course, never trust the box. We cannot, possibly have a library of these lenses. So verify before you block the patient. So the other options in these cases would be an aniridia ring or aniridia SFILs. Both are challenging, and I have done both. The aniridia rings are also very delicate and can break on the table. The suture options are either 90 Prolene or 80 Gore-Tex. I have not used much of Gore-Tex, but that is another option. We can use a straight needle or a curved one with the curved on the other side. The preferred one is the straight needle. We have also learned that the optic is pretty large, almost 9 mm, so you need an adequately large tunnel, because if it's a shorter tunnel, then there are chances that you might break the haptic while introducing the lens. So again, the optic haptic junction is pretty fragile. These cases, aniridia cases per se, and the implantation of these IOLs also has chances of secondary glaucoma. So long-term follow-up is required for these cases. So thank you so much. Okay, so Shalini ma'am, are you there? Yeah. Okay, so I'll invite the, probably madam is not there. I'll invite the panelists for any comments.
It was a very nice case, Dr. Devakant. It was nice to see this entire thing. I just have one of the queries that, you know what, actually I have experienced with these, specifically with these IOLs. I don't know if you have seen this patient in the postoperative period. Do you see like you have that, pigment dispersion coming off from the lens itself? And the coating that we would say for the aniridia, what they do for the iris, these IOLs, they are found to release those brownish or something, those pigment kind of things, and they actually lead to secondary glaucoma. So I have seen two cases like these, and at the end what you will see is that these IOLs, they try to fade out from the area from where you have that iris structure. So have you come across this?
Ma'am, very good point. So this patient is now under 6 months follow-up. So luckily, I've not seen that happening yet. Uh, I have two or three other cases. In one cases, I did notice it. Luckily, the secondary glaucoma is managed. This patient has some rise in IOP, but I could not see any dispersion of whatever that paint or that chemical is. But I'm closely following that patient. The other eye also needs surgery. So I'll see, but not yet. But in one of the cases, I did notice it.
Okay.
Priya madam, I think it's not very common because we do lot of analytic SFLs in the trauma centers. So we don't see that. Yes, there might be slight fading off, as you said, but we don't see the complete going off and patient complaining about it. Just recently, we did another boy. He's now 6'9" vision, not complaining of any photophobia or anything.
Yeah, I'm not concerned about photophobia in these patients. I'm only concerned about
About the
those
dispersion
pigment
or
going, yeah, the
that
pigment
fading off.
dispersion going on.
It's
Yeah.
not that common what we see. Secondly, I just wanted to tell Diva, if I have 30 seconds, Sharshul asked me to show some of the video. If 30-second video it is, I just want to share
Okay.
another technique how it can be done is because these 9 prolines, what we are seeing is getting degraded early.
Yeah.
So
Yeah.
now the better would be to go in for 6-oproline or the 5-oproline. So I think that would give a better strength and better support. So I just wanted to show this. You can see this is my screen shared. Sorry. Where it went. Okay, I'll open this.
Has anybody tried making flanges in those two holes, with the 5-oproline or with the
And
6-oproline?
this
And
is what I'm showing there, madam. You
oh,
can see
you're
this.
showing that. Okay, fine. Great.
See this, I'm just inserting the 6-oproline here and making the flange. You can see there in one eyelet.
Yeah. Yeah,
Similarly, make the flange in another eyelet and check it outside because it should not
absolutely.
give away. And then take it inside after making the tunnel. So what here I've made is to make a flap because even if the flanges are unequivocal, it might erode the conjunctiva. So under the flap, if you can see, it sits out very nicely. So these are
Correct.
some of the ways where the strength of the SFIOLs will be much stronger, and especially if the patients, these are the patients who might go in for retinal detachment or any of these things in future. So we need the stability, and it gives a good stability also, and hopefully if 9O is getting degraded, then less chances that 6O will get degraded, but that might also, but we need to have a very long study to really prove this point.
Yeah,
Thank
because now surgeons who are even using Gore-Tex, even they are coming up with degradation of Gore-Tex
you. Yeah,
sutures. So it is not
exactly.
that something which is just not degradable. You don't know
Correct.
what happens after 15, 20 years down the line.
Very true. Very
So
true.
I have also used Gore-Tex for this. I've not had it degrading till now. It's only 4 or 5 years now, so it may take more
Yeah.
time.
Yeah,
Uh,
they're reporting after 15 years, Gore-Tex is also degrading. So I don't know because I did
By
not use Gore-Tex 15 years back. So, but
They will
surgeons who have
forget it,
used it,
madam, by
yes,
then.
I don't know.
They'll again put a new Gore-Tex again after that. So again, 15 years more.
Yeah.
There's something I don't
One more
have
thing is,
specific.
one more thing is, we have the 70 proline with needle attached to it. Oralab makes it, and I
Ah,
use that one for one of these cases to flange. So if you flange 70 proline, they keeping on flanging it more and more does not increase the size of the flange. That is what I
ah,
realized. So it will not fit into these kind of lenses. The hole inside that the one which is
I-
the haptic, it's not standardized. Sometimes it will be slightly smaller, sometimes it will be slightly larger. So I have had it go in. I tried it outside. It was no, it was holding. Once it was both inside and the infusion was on, it flipped like this and fell into the
ah.
vitreous. It
Yeah.
slipped, both slipped through.
Yeah.
So if a 7-0 is flanched like that, it is possible that it will flip through. And so I would say then we had to change over to the 5-0, but 5-0 made a bigger flange and that stayed well. So that
Yeah,
is what I flange.
I also have a suggestion that when we make these flanges with the maybe a 6-0 proline or whatever, we try to revert it, like, after making the flange, just compress it so that it becomes much more flatter and it has a much more wider base rather than the typical round one. So it will probably stay much more and hold on to that small gap into that haptic. Well,
So coming to the proline suture, the 9O specifically, what timeline? I've read that it's around 6 to 7 years after that it starts degrading. So do you feel it's the same in your practice?
9 to 10 years, Diva. I
9 to
think what we are seeing, but some of them are very lucky. Even 12 years, 13 years, I have seen Dr. Guruprasad are operating 15 years. I have seen 18 years. I have seen some, I don't know, they get through. But we have seen a lot of one haptic falling down.
Okay.
So not both the things, one haptic, and we have refixated almost around 18 of them. We have refixated in 2 or 3 years. So hopefully we are collecting those cases because the EMR came to our system pretty late, almost 5, 6 years ago. So hopefully we should have a good data. 18 we have done intravitreal fixation, like doing it in the vitreous cavity and trying to fix it back rather than explanting the lens. But I
Right.
think around 8 to 10 years is what I assume it, not from the study.
I
My
think
personal.
what I
One
assume is
one
that
tip that
the,
okay.
yeah, sorry, please carry on.
One tip that I would like to give in a lot of these scenarios, once you have passed the proline suture, whether it's 9O or 10O, and brought it out into the sclera, you often try to be in a hurry to tie the knot. I think it's important first just put a single throw just to hold the suture in place on either side, normalize the pressure in the eye, and just give enough tension to support the lens. You don't have to really, make it very tight against the sclera. So if you give that little bit of laxity or you don't make it over tight, you will find that the chances of the proline suture eroding through that sclera would be less over time. So I think it's important that not in a soft eye, so don't keep the eye soft when you are finalizing your tension in the suture for the haptic. Always normalize the pressure. Then put in a gentle throw. Always remember to put at least 4 or 5 throws because proline knots are not as secure as nylon. And leave the ends a little bit long. Don't cut them very close to the knot because then your knot will tend to open up. And if you take these precautions, I think it stays for a long period of time. I've seen people take the bites when they make 2 passes through the sclera, they make them very close to each other. And then, the suture can cheese wire through that over a period of time. So I think in your surgical technique, if you follow some of these points, maybe you can prevent it from, degrading faster over a period of time. Same thing with the flange. What Minu pointed out that, instead of intraoperatively figuring out that the suture does not fit into the hole of the haptic on the haptic, try it out before, even before you put the lens into the eye or before you start your surgery, take your suture and try to create a flange and pull it and see whether it stays secure in that haptic or not. If it is slipping through the haptic, that means you need to go for a suture that's slightly larger in size, thicker.
Perfect, perfect. Thank you. Priya,
I
ma'am,
always order for at least two of these ones. Although it may look steady like that, it may slightest tilt or pull on it will break off from the. And similarly, the aniridia segments that also halfway through while passing in it will break off. So at least have at least two as backup. So aniridia also ring also I get always two and have backup. Send it back if it is not used. That is fine.
aniridia rings, I feel, are very fragile. So it's slightest bit of manipulation and it breaks away.
Thanks.
Yeah.
Does anybody have any experience of fixing up the artificial irises with the 3-piece IOL and fixing it up?
Artificial irises, I've seen, but I think I don't know if they're
Too
available in India
expensive.
yet.
Too
Yeah,
expensive.
no,
For
they,
They
they
have
are
to
made
import
on
it from
order.
Australia, and people have done that. It looks really good, but I have no personal experience.
The cost is about 4,000 to 5,000 euros for one artificial iris. So that's cost
Yeah,
is one
that's
of the
from the
reasons.
Morsher, but I think there is
Morsher,
a
yeah.
Russian,
There's one Russian company
yeah,
that costs about $2,000, I think.
yeah, that costs less, and they can be custom made within 1 month or so, something. But still, it's an extra cost.
Perfect. I think we had some wonderful points. We'll move on to the next talk by Dr. Nivin. So he'll be talking to us about CMT flex and the right technique to do it. Over to you, Dr. Nivin.
Thank you, Sukant. Just sharing my screen.
Sir.
Yeah. Is it visible?
Yes,
Yes,
yes.
please go ahead.
Yeah. So, respected teachers, senior ophthalmologists, my dear friends. So, I'm going to talk about CMT Flex IOL as a new option for aphakia. I do not have any financial interest. So, I'm just going to go through a couple of case series. So, this was a case of a 360-degree subluxated lens secondary to microspherophakia. So, it was planned for a lensectomy with a secondary CMT Flex IOL. As you all know that all inventions came with the question why. So that's how mine also started. As we have the series here, we know we all started with the suture technique and then moved on to the glued IOL and then to the modifications like the X-nick technique and the Yamane technique. They're all different modifications of the 3-piece lens. So that is what led to the birth of the CMT Flex. For any secondary IOL, the 0-180 degree marking is very important. So we use the Ashwin's glued IOL marker to do the 0-180. And then we fashion a 2 by 2.5 millimeters partial thickness scleral flaps. So I like to do this using the crescent blade. So I just enter it, give a mild counter traction on the opposite end and just come out and then slice outside. So this way I make it easier for creating the flaps. And then 1.5 millimeters away from the limbus, we make a 23 gauge sclerostomy on either side. So in this particular case, we had the lens also to deal with. So I'm just holding the lens with the same needle using the same sclerostomy port. And then with the cutter going through the posterior thing, since it was a very soft cataract, I was just lucky. So with good suction and cutting rate, so the entire lens, making sure without dropping it back. So we all know when it goes back, it's a different ball game. So this is the CMT Flex IOL. So basically it is a single piece hydrophilic lens with specialized T-shaped haptics on either side. And then as you can see here, the other advantage here is you can be done through a clear corneal incision. And we also have two specially designed forceps. As you can see here, this is the Pranav T-Flex forceps, which has just got a broad tooth in the tip. So basically you can use any other forceps also as long as it is not sharp. Because one of the initial questions I used to get it was chipping away or breaking. So as if we use any of our VR sharp instruments or the ILM forceps, because being a hydrophilic lens, when you press it, it bites into the lens. So that is the reason when you pull it out, it chips off or breaks the haptic. So here, as you can see, as soon as the tea comes out, just wait and keep it in the cartridge. So this makes it easier for us to hold. As you can see here, I'm holding the neck portion of the tea junction here. And the third trick is don't pull it out now, because again, it's a single piece lens, so it can detach. So I'm just releasing the remaining of the lens from the cartridge. So once the entire lens is free from the cartridge, you can leave the trailing haptic on the wound or above the iris. And then since the lens is free, you can use how much of force you want to pull it out. It just pops out. And then because of the specialized T-shaped designs, it just sits there. So basically this avoids any suturing or tucking. Just a small animation clip. It can be done through any IOL cartridge. But the thing is, just make sure that the tea comes out first. So it is actually easier for us to grasp, because we inject too much, then it starts bending and moving inside the eye. So I just inject little, grasp it first, and then inject the remaining of the lens. And then once the lens is free, you just pull it out through the sclerostomy. You can hear a slight pop as it comes through the sclerostomy, and then it just sits in position like that. For the second side, I use the handshake technique. So you can see here, grasping the arms of the IOL. If you use the Nishi grasping forceps, just serrated forceps, and then feeding it to the other T-flex forceps, and then gently pull it out. So the other trick is at the sclerostomy, I don't try to pull it out. I just wait for it to slip and come out. So these lenses are stretchable. So we also titrate the water curtain, such as some amount of stretching does happen. So once that is done, as I said, 180 degree is the whole key for the entire surgery. So however you're going to mark the sclerostomies, that's how the lens is going to sit. So that practically becomes the end of the surgery. And then you can either glue, initially we're using the glues to close the conjunctiva and the flap, or you can even suture it, or even you can just cauterize it. So why I'm saying cauterize nowadays, I just cauterize it because these haptics are thicker. So basically it fits into the sclerostomy and doesn't cause any leakage or hypotony. These are some of the day one pictures and 1 month post-operative pictures. You get nice round pupils. So these are initial studies of UBM just to show the position of the lens. And we also did some studies on the sclera just to see any long-term erosions are there. As of now, I think almost we have like a 7-year follow-up data that has been published in IJO also now. So these are some of the various publications that we have. So moving on, lots of people have started using it and I've got a lot of ideas from others. So just moving on to some of the tips that I could suggest. So initially we were using the needle, and then now slowly we moved on to using the MVR blade. So basically you get a sharp cut on both sides rather than the needle, which is like a round cut. The other thing is we started doing a vertical incision, a 90-degree incision to the limbus. So when you do the vertical 90-degree incision to the limbus, instead of making it parallel, the T actually sits at 90 degrees. As you can see here in this picture, initially I was using to make a parallel limbus. That's how we are taught. But nowadays we started making perpendicular incision so that the T sits at 90 degrees. So basically when you're pulling the other side, the less chances of it slipping back inside. The second thing is we also have an angulation for these lenses. So initially it was 5 degrees, now it is 10 degrees. So it's almost, it's like a hammock here. So basically this is because it is fixed in the sclera. It is basically to make sure that it stays away from the iris so that there is no rubbing of the iris causing any irritation or iritis or any pigment dispersion. As you can see here, there's a gap there between the optic and the haptic. So that's like a 10-degree angulation that's been given. That is marked through the holes on the other two sides. The other trick is we call this as the head-on position. As if you must have seen in my first video, we are always used to the superior tunnel and injecting the lens. So that time there is some 90 degrees that goes. As I said, this is a foldable lens, so we can actually make our clear corneal incision wherever we want. As you can see here, if it is opposite end, you can just feed the lens. And as you can see, this is the head-on position. So the basic advantage of this is when you're pulling it out of the sclerostomy, the haptics bend inward. So when the haptics bend inward, there is a smaller diameter of the lens haptic that actually comes out. So it is slightly easier and smoother when you pull it out. Rather, in the first video you saw, I was holding the neck. So I have the entire bulky portion trying to come out through the 23 gauge sclerostomies. Some of my colleagues have even used the dialing holes for the exchanging of the other haptic. Instead of doing the handshake technique, they use the dialer to pull it out. Some of them have put sutures and kept it outside. So the initial days, so that they are not losing it into the vitreous cavity here. As you can see, the head-on position used, so slightly smoother when it comes out. You can see the haptics on either side. And the other thing is, even for anterior segment surgeons, I think the trick for any secondary IOL is making sure the eye doesn't go into hypertony or you do too much of trichotomy or things. So always, so this was a case which had a single piece rigid lens that was dislocated due to the fibrosis of the back. So here we are using the AC trocar maintainer, again another invention by Dr. Amarkarwal. So this, even though it is long, you should just be careful we don't hit the iris. So I'm just using it instead of the AC maintainer. So since this was a rigid lens, I had to make a full sclerocorneal tunnel. I don't prefer opening up the conjunctiva in any of these cases. I always make a fresh tunnel. And here, this is another modification that my colleagues is, instead of making the sclerostomy, we can even use the trocar. So why? Because I've heard that people say, even Shiva said that the instrument sometimes hits it and then it gets stuck at the sclerostomy. So here, instead of removing the IOL, make sure you just grasp it and do a good vitrectomy so that you free the IOL from all the adhesions before you remove the IOL. So once the IOL is free and it is removed, here again, I'm loading it into the cartridge. Even though I've opened the section, I've tried placing the entire lens without the cartridge, but somehow I find it easier when it is loaded into the cartridge for two reasons. As I said, I want only a small portion going out so that it is easy for me to grasp it. And I'm keeping the forceps close to it so that I can just hold on to it before most of it comes out and starts wobbling in the anterior chamber. So that makes it easier for me. So that's the reason why I use the cartridge even when I open up that sections and just pulling it out. So after the one side, the other side, we also come up with these curved forceps because near the nasal edge, sometimes getting these angulations to pull out these lenses are difficult. So now we have these curved forceps that are easily done. As you can see, I'm going in through the trocar, and this is the head-on position, as you can see here. So only thing is we have to make sure that we remove the trocar first, be gentle and keep watching what is happening actually. And then you can see the haptic slipping out. So just small modifications that I learned along my journey through all my other friends and colleagues who have been doing the procedure. So as you can see here, well-centered lens. Once that is there, you can remove the AC maintainer. Sometimes I put in an air bubble to leave it. So the journey has been a long 7-year journey now from where it started and from the first design, from the launch of it to where it is today. And the next step is to also come up with the toric or the multifocal version. So here I will definitely like to thank all the people that were the initial users and gave me the suggestion. I think we have the Divakant here, we have Minu Mathun sir and Srinivas. I think combinedly they must have used more CMT flexes, and I've learned lots of things that they taught me to change my techniques or modifications where it is presently today. So once again, I'd like to thank Harshul, Namrata ma'am, and All India for giving me this wonderful opportunity. Thank you.
Thank you so much, sir. Beautiful lens, and the modifications that you have done and improved the lens and the technique are commendable. And as you said, I've myself done, I think, more than 200 of these and have a great experience. I just wanted to know, you must be having a very long-term experience with these lenses. So how has been the long-term stability and any complications that you have seen with these lenses?
See, some of the common complications that we see with any secondary IOLs, even I've had one case of a retinal detachment post, but then I've gone up and seen the video that is more because of the traction on the first primary surgery that had caused it, like vitreous hemorrhage. Those things are common. But breaking, I found it was only because we tried to put too much of pressure while holding the lens, keeping in mind that we don't want to drop it. So more and more we press, it actually bites into the material. So that is why I prefer these flat forceps. And as long as you have a grip, just you don't have to put too much pressure in that, because initially when I was doing that, so it doesn't actually break. And I think once it is fixed, I think long term we have not seen any dislocations in these lenses. I've had one case again. where I realized I have those videos where the sclerostomy was made larger, because when it's not coming out, no, we tend to go back inside and extend the sclerostomy a little more so that it makes it easier for it to come out. So in those cases, it becomes larger. So then it has chances of slipping. So what I learned again there was that you can just put an X suture once the haptic is out. Like we used to close the 20 gauge sclerostomies, no? So around the haptic. So that actually secures it in place. Or if you have a thinner sclera and you're not sure. So these were my experiences. If anybody else, I think Minu sir or Srinivas,
Yeah.
long-term
Yeah,
complications.
your inputs.
Okay. Sorry.
Yeah, Srinivas, carry on.
Yeah. Good talk, Dr. Nivian. In fact, I think it's a similar copy type of Caravale kind of lenses, if you know it. And I think they stopped it, and India somehow picked it up, and now India is booming up very right with this Caravale kind of lenses. Uh, One thing is, yes, definitely, we shifted on from the 23 gauge to the NVR blade. But now what I'm doing is using a 25 gauge stroker. So similar way, use the 25 gauge stroker, make a vertical slit because the trokers also have a triangular shaped blade. So just make a stab entry and you can extend a little bit if you need it, but otherwise I don't feel the necessity of extension. And secondly, as you described it, use a non-toothed forceps or anything like that, ILM forceps, which is not sharp. Just try to expel it out from the sclera, and it sits like a T. In fact, I remember I was the first to tell you that it fits like a T, and it's always better. And people have named it like a copper T also. I just joked on that. Some people commented on that when I did a live surgery
Life surgery.
on that. I hope you remember that, Nivian, just on a lighter
I
note.
forget. You made it famous.
Yeah. The third thing is, yes, the common complications, as Dr. Nivian said, is the breakage of the haptics because he uses a single surgeon now where we have a lot of fellows with us where we have asked to do the CMT flex. We have seen a lot of breakages happening when the initial beginners are doing it because they don't hold it at the T. They don't hold it at the neck because they try to pull it with one end and then some or the other it tries to break it. It tries to break. The third point is we have seen the rotation also. After fixating, it sees well, but later on we have seen that the T rotates a little bit under the flap. So in those cases, those are the cases where it got a single haptic dislocation. So what we did was we little bit moved the entry. We made another entry and pulled it out and made another T shape. If the tilt is more, then explant it and put a new IOL altogether. But if the tilt is less, then we can still go ahead. I recently did one case where I think the T got rotated and it went inside that vertical slit like stab and it fell inside. So you
Okay.
can just try to bring it out and
Twisted.
never try to go with the same entry. Always try to make a different entry because it's a small vertical slit what we are making. So we can always make a little parallel around 1 millimeter parallel to that slit. It still stays good without much of rotation or because we did the shin plug imaging. We looked into the slit with the anterior and OCT. We are trying to look into what is the amount of tilt, astigmatism, all those things we are studying. So we are comparing these three lenses, sutured lenses versus CMT flex lenses versus the Canabrava, the Sergio Canabrava technique. I think we have completed around 150 cases by now, and slowly it's in the manuscript revision. But we have seen good stability with the CMT flex lenses. Let me tell you that. The stability, the tilt, and all these things, what we have seen in the initial pilot study of 150 cases, is the stability is good as compared to other suture techniques. But my only concern is people were asking in the recent APAO, like if there is a silicone oil, what is the kind of opacification are these lenses going to have? Or even if there is no silicone oil also, what are the kind of opacification or any other alterations which, because it's a hydrophilic material, so the complications of hydrophilic material still exists. So these are the few points I think because I'm a vivid user of CMT Flex, so I thought I wanted to share it. Thank you very much.
So I think I have also used some of these. I've discussed so much with Nivian. So the points in the technical modification of surgical steps. That is the first thing is to create a larger flap than our regular glue diol with the PMMA haptic. So I make it 3 millimeters broad. That is 3 millimeters by 3 millimeters, so that the haptic fully gets covered by the flap. That is first thing. And the flap is made slightly thicker than your regular half thickness, slightly thicker than that, so that it covers it completely. Sometimes there will be some tenting up at one side, where I would definitely suture that also on the corners. And the third thing is the incision for the IOL. It is very important that we make it closer to one flap, so that the T comes out like this and you can catch it exactly here. So if you go 90 degrees from the flap, it is very difficult to catch it like this, and pulling it out can cause damage to the T. And even in a case like what Nivian showed, if it is scleral incision, which is 90 degrees, I would abandon the scleral incision, make a 2.8 clear corneal incision near the flap, and enter through that. I don't like, again, as like you said, to do it without the injector, because it is more controlled way of injecting the IOL. And the horizontal one, see, generally, if you make a 23 gauge opening, even if it is parallel to the limbal parallel incision, it stays very well. 23 gauge, if it is exactly. But then when you are coming out, it is very easy that you may tilt it slightly you tilt your hand, or the blade tilts. I also use an MVR now. Then it gets slightly extended. And especially if your sclera is thin at many places, many of cases we find that in one area the sclera will be thinner than the other side. So if you make a flap of same thickness, the bed will be very thin, and it is very easy to just cut and make it slightly larger. As you said, it is always better to make X sutures around it and tighten it there. It stays. The two cases I have done that, and it has stayed. It just slips off during when you exteriorize the other T. But otherwise, again, why it rotates is what Srinivas has to tell. But I have not seen it rotating except in a very large eye. And if you're trying to tighten it taut like this, sometimes it can twist and have a torque. But otherwise, I have not seen it rotate and come vertical or whatever. So I have also started changing over to the vertical incision, so that you have more support for the T-shaped haptic. Otherwise, we have never had for more than 2.5 years. We have followed for 2.5 years, but we don't have any erosions, subluxations, glaucomas, nothing of the sort. And these lenses, again, depends on what material it is used, and then only it becomes opacified and all this. All hydrophilics do not turn opaque, or they don't calcify. It is the kind of raw materials which a particular company uses, and if it is standard and good quality, that doesn't happen with all hydrophilics. And thanks and congrats to Nivian.
Thank you, sir. Srinivas, can I ask a question? You use the 25 gauge forceps also, because you said you make the 25 gauge incision. I think Srinivas is there. Huh? I think he must have gone.
I tried initially, so that because it is difficult to bring it out. It feels like I am going to break it, or there's a lot of traction, and sometimes this flimsy 25 gauges slip also. So I thought 23 is good enough, and you have enough haptic sitting on the sides, even for a horizontal cut. So
I use the 23 gauge.
But remain exact 23. No extensions at all,
Yes, sir. Thank you, sir.
So again, we'll move on to the next presentation. May I invite Dr. Meenu Mathin to talk about glue dial technique. Over to you, sir.
Yeah, I'll share my screen if it is seen.
I can see it, sir.
Yeah. Thank you very much, Dr. Harshutak, Dr. Namrata Sharma, Dr. Divakant, for this opportunity. And this was my go-to technique over many years. And now CMT Flex has started taking over, but then still this is my very loved technique to tackle aphakia as a secondary procedure, skill fixated haptic intrascleral tucking. So these, as we said, forceps are very important. Glue dial forceps are available, and markers are also available. We can either use Mendes ring to mark 180-degree opposite, is very, very important, or use this also to mark 180 degrees, but Mendes ring will be better, so that you get exact 180 degrees. For the regular IOLs which we use, I make only a 2 millimeter broad and 3 millimeter backwards scleral flap. And for infusion, if you are going only anterior segment, you make a paracentesis and then use AC maintainer or a trocar cannula. And previously, I used to use this 23 gauge needle, but now I use MVR blades only, to 23 gauge. And this is the knife which I now use, 1 mm knife for the intrascleral pocket. You can use a needle also, but I find this one more comfortable. So I again make a paracentesis. Exactly here, the opposite of what we said just now. It is 90-degree opposite to the flaps which we have made. And this is our for this one sensor thickness or the overlap lens. Holding at the tip is very crucial, and wait till the optic is open completely and position the other optic very well, and then pull out the tip. And my technique is to use a stopper, silicone stopper, to thread it over the needle, and then needle the haptic is threaded into the needle and the silicone stopper. There are other ways, many other ways to do assistant less technique and holding by some other assistant and all those. So then goes the second haptic inside, and you hold it with the microforceps from the other paracentesis which we have made, and the other end is again held. Make sure you hold only at the tip, and it is exteriorized. And now we can see that the haptic is outside, and generally what I do is to introduce that haptic into the tunnel initially itself. So that is placed inside and tucked in, and then come back to the previous one and tuck that in also. And then I always make sure that you can see that these two P1 and P4 are overlapping at the center, and it is equidistant from the ends of the IOL, and that makes sure that the lens is well centered. And after that, I hydrate the paracentesis and the incision. And the incision can be sutured or not sutured. Because it is 2.8, I sometimes suture these incisions. It's good that you suture and make sure that there's no other leak, so that you can focus on the sclerotomy and the flap part. And after taking out the infusion, we replace air in the anterior chamber, and then put the glue under the flap, and then flap it down. And also for the conjunctiva, if it is well cut and dissected, you can use glue also. And sometimes I feel that when there is a lot of subconjunctival fibrosis and all those, getting a flap like this may not be that very much possible, and I sometimes suture the edges of the flap also. So this is another case where there was a subluxated lens into the vitreous, and there was a central PC opening and a lot of Sommerings rings. And the same procedure after the hemostasis is very important. So when we are making a flap like this and then making a tunnel, hemostasis is very important, so that the level, the depth of it, you can use a 15 blade or 11 blade, or my preferred thing is to use this crescent knife. And you should just see the crescent knife under the flap, so that is around half thickness, and then come to the other side and just open it onto the side. So now I realize that I'm checking for the remnants of the capsule. So the pupil is small. I don't do anything without seeing. So put the iris hooks and enlarge it. You can just see that almost completely 360-degree the lens, the capsule bag is free. A lot of Sommerings rings. The IOL is inside the vitreous now. So I know that there is a technique that you place the glued IOL first, support it, use it as a scaffold for not letting the Sommerings rings fall down. But here I take out the hooks and make the pupil smaller, and under the support of the oro whisk or the sodium hyaluronate, I take out all this, and then we go in for the IOL which is there inside. It's already a vitrectomized eye, and we have the vitrectomy backup standing by, and we lift up the IOL. It's a 3-piece IOL, and it's a Technis IOL, and so I exteriorize it into the anterior chamber first to examine the IOL, because the long-standing if the IOL has been placed long time back, the haptics may be deformed. There may be some deformity of the IOL. Then I do not use the same IOL. But if otherwise, if haptics are doing good, then we can always use the same IOL to exteriorize. So sometimes when the limbus is not well defined, you can see the blue zone. 1 millimeter behind that, you make the sclerotomy, and then you exteriorize one haptic, making sure you hold only the tip of the haptic and exteriorize one end of it, and go to the other side and again fixate this haptic and stabilize the haptic there. We can make the scleral pocket beforehand, or just before exteriorizing, or even after exteriorizing, just to see the orientation of the haptic and then doing. But then that will be a little cumbersome with the haptic sitting there. You can do it beforehand itself, parallel to the sclerotomy, and then tuck it inside and come back to the other side, and always make sure that the centration is correct by matching the P1 and P4. This is the way I do it in some cases. Hold a little behind, tilt it, bend it a little and tuck it in. It's very easy. but there are complications which can happen, which I will come to. And this way you can close it with the glue, and then like what you saw before itself. So to refine it, some points which we need to make sure. Previously I used to make 3 into 3. So then the haptic fixation into the scleral pocket will be less. So you'll have less tucking in. So now I've shifted to 2 millimeters only. And so you have more of haptic tucked into this one. So again, you can see that this incision is little away from the central point between these flaps. So then now bringing it in, see the way the lens is tilting and all those. So it is more cumbersome. So go 90 degrees away from the scleral flaps for as the entry. And here again, you can notice that this is my way of stabilizing the haptic. There are other ways, as I told you. But if the tip is deformed, then it is very difficult to tuck it in. So always make sure you hold only at the tip. And if it is slightly deformed also, try to straighten it out. Or even if you get a very small one, you can even snip it off also. And so then threading it into the 26 gauge needle is much easier. And this is just a scleral, the silicone stopper of a Grishaber iris retractor hook. And here, this is the way I do. Don't go into different planes. Don't hesitate. Make it parallel to your sclerotomy and go into the sclera, not very deep, not very superficial, along the floor of your flap, which you have already made. And here again, you can notice that once we have exteriorized, see the direction of the haptic. So the hold was here, and you finally get a half T kind of a deformity at this one. So that is a thing which we need to avoid. Hold only at the tip and move in the direction of the curvature of the haptic. And sometimes when you are holding, when there are, see here, there is a big scar here, so you may not be able to see it very well. So hold it at the position where you're comfortable. And now you can do a double handshake. Hold it again with this one, go close to close to it, and then come back and hold at the tip of the haptic. So this way you can do multiple handshakes so that you can finally come to the tip of the needle. That's very, very important. And here again, some small pupils, you might hold the tip, and then once you have held it, then you will be focusing on the haptic going in, then the optic going in, and by the time you will somehow lose the grip. And if you have lost the grip, then you will come out without the haptic coming out. So make sure once you have held, do not loosen the tight grip. There is no harm tightening it, unlike the T. It doesn't cut through or nothing happens. So then if you're losing it, then if the small pupil is small, again we have to dial it back in and then hold it back again and take it out. Again, this Technics IOL, nothing against it. See the way it was pulled so much backwards. See, when I was trying to tuck it in, it was too much angulated backwards, and I had a breakage of the haptic once. And then going back again, it was I could identify that the tip was there, and so I could retrieve it and tuck it back in. So holding it parallel to this one, again, this is the worst thing you can have, one more break, so these things can happen. And so don't tilt it backwards or bend it too much. Bend it downwards and hold the forceps parallel, or use the second instrument like what I am doing here. See, parallelly pulling back, and then hold the second instrument to open up the sclerotomy, and then the pouch, and then lift it up and then open it out so that you can intrasclerally fixate much better. The other thing is the infusion. So if you're going anterior segment, you can use an AC maintainer or a trocar cannula, but the AC maintainer problem is that we don't know exactly what is the size. It comes in different sizes, and it can be difficult to put it in, or it might sometimes leak or just come out if it is slightly larger in size. So I nowadays use only this. You can go limbal, or you can go clear corneal, but the problem is this is very large, made for the posterior segment, and make sure that you go a little bit into the sclera and then turn it into the center of the anterior chamber so that you don't hit the iris or the IOL or whatever, or the angle. So that, and then once you finish it, it can be pulled out, and most of the time it just closes with pressure. And if it doesn't, you can always suture or put some glue. Or see here again, I'm going clear corneal, but again make sure that you don't go too fast or use too much of force that you can go and hit in the angle or the iris. Turn it towards the center of the pupil. Or if you see the cannula just inside the anterior chamber, stop there. Don't push the whole thing inside. After taking the trocar, you can push this one out. So once it is taken out, infusion is gone. You wait for some time and see. Sometimes it is a little round and it doesn't close completely. If it doesn't, you always can put a suture and close it off. So here you can notice that I am using an IOL which is PVDF haptics. they do not break. That is one thing which can help you. Only one company makes this, but it is not required. But just to know that there are IOLs with PVDF haptics which are non-breakable. And one thing which with all these modifications, you can come out very easily. One more thing which I have done here is you can make a trocar cannula which is smaller in size. That is, I can show you that. See, this is where the cannula ends, and the trocar is so large. So if you just cut two of these silicon bands and put it in, and then put the trocar there, so more space is occupied here. Or you can break off one of these stubs, and then see this is put there, and then one more of this stub can be taken off from one of the trocar cannula and put it in, and then put this in. You will have only a small end of the trocar extending into the anterior chamber. That is one small modification. There was one which was made for the anterior chamber also, but it is slightly costlier and it has to be. I don't think it is required. We can use it this way also. Thank you very much.
Thank you so much, sir, for demonstrating this technique beautifully and all the caveats around it. Srinivas, sir, your comments?
Yeah, Meenu sir, as always, treat to watch your videos, wonderful videos. The only thing is, yes, it has been tested well in the past, and still many people are still following it. Although new innovative techniques of doing a secondary SFIOLs have come into the picture. Earlier, everybody used to go in for the intrascleral fixation of these things. The only disadvantage where I find it is the trailing haptic. And once the configuration of that haptic is lost, then really it becomes difficult to put it back. Second thing is, I always ask beginners to make the scleral track after externalizing the haptic. Sometimes we might lose where we have done it and keep searching for it. So it's always better. I found out that externalize it and then put it back into the scleral tunnel. That would be much better. The I don't know about the silicon plugs what you have used. It is just to stop that the one side of the haptic coming out unless you externalize other or you keep it there for forever.
No. Till you tuck that in. When you
Okay.
exercise the other haptic, this will prevent it from falling off. There are have your assistant can hold it.
Or it's not come
There
out
is
that
pre-arranged
silicon.
a stone that you need not have that at all. But I just feel it little safer so that it will stay there. I don't want to go in back again and pull out and all. And the point which you said is, I use blue to stain the area where I have created the intrascleral pocket.
Yeah,
Otherwise, it will stay. You keep on searching for it is difficult. So you can always stain there.
yeah. The
What I
only
think would
sorry, madam. Go ahead.
Srinivas, finished? You were telling about all this, you can finish off.
I just wanted to tell others how do you not cause the disfigurement or of the trailing haptic? How do you still maintain that haptic angulation so that it, because the leading haptics always sits, you can externalize it and put it fast. But when you try to remove it through the opposite end on the other side of the trailing haptic, that is when the bending happens. Of course, you showed the handshake technique and try to always use the tip of that haptic so that if you hold it at the mid, then it might get bent. But still, any other ways where you can tell the beginners of how to avoid this? And second,
I like to highlight this aspect very well because trailing haptic is handling the trailing haptic is it's quite tricky. It's not only trailing but even for the leading. The only thing is the movement of the hand. That is where it comes. Like if you just hold the haptic and you keep on pulling like this, you are obviously causing disfigurement. But if your hand movement is like this and then you hold it and you come across along with the curvature, it remains as it is. It does not happen. But if you just keep on pulling, it happens. Second thing, what Dr. Mino, I think I showed was the use of the hook plugs that we often use. We use those plugs, especially when I use it when we have a lot of complicated cases, like you're handling too many things going on inside the eye. For example, you're also doing a pupilloplasty, you're also removing the sombering, you're also doing the secondary IOL, the glued fixation. So what happens in these cases is that sometimes, like when you are doing a pupilloplasty specifically, your needle might hit the secondary IO that you have already fixed and it might cause dislodgement. So many times what I do is that I will just externalize my haptics and fix them up with the hook plugs or whatever it is, and then finish off the pupilloplasty and then remove those and then tuck it off. So I think these are one of the, I think Dr. Steve Safran and Dr. George Baiko, they had explained, they had come forward, Roger Stannard, they came forward with this technique. The point is, many times we do not even have those iris hook plugs. What we do is we take up that IV set, and you can just cut that IV set into small pieces, and then you can use that similarly like what we do for an iris hook plug. So you don't even have to get a fresh set of iris hook plugs into position. But I think these are some of the tips and tricks of doing every technique. Basically, whatever technique you do, every technique has its own nuances, it has its own complications, and everything which needs to be handled accordingly. So these are, I think, some of the few things. I think main thing for the trailing haptic is the hand movement. That is where the trick lies.
Yeah, Srinivas, once the tip comes out, when we should realize that this is not a straight thing. It is curved like this. So the
It's a
tip,
drop.
even if your wrist doesn't move, the tip of the forceps should move forwards and along. You should imagine where it's going to sit. Move it along like that. So I showed one case where I was holding it backwards like this and then bringing it. Then it makes it bend like this. So once you held it and it has come out, turn your hand in such a way that it follows the curvature of the haptic, and it usually comes out, doesn't damage it. Mine is the leading is the one which gets usually what I showed. Trailing, nothing happens for me. So maybe my right hand is moving much better in that direction or something like that. Just anyway, imagine where it is going to lie down and where it is curved and move it along like that. It works.
Great. Thank you. Next,
So,
Rajesh sir.
so Dr. Rajesh,
Sure,
sir,
I'll
your
just.
comments? Yeah.
No, nothing. I think excellent points. It's difficult to add after so many experienced surgeons sharing their points, compared to them, I'm still a novice. Yeah. Let me just share my screen and I can give my talk on.
Yes, so now I invite Dr. Rajesh Vogla, sir, for his talk on Yamani's technique. We know he is a prolific surgeon and director of Apollo Hospitals, Hyderabad, visiting professor to University of Wyandotte, Argentina, and also to Sri Lanka. Sir, we are fortunate to have you here. Please
Sure.
go ahead with your presentation.
At the outset, I would like to thank AIOS and Harshul for making me part of this symposium. I'll be sharing my experience with the Yamane technique. We heard about the various techniques of IOL fixation. What we have not heard is iris fixation, but I think the rest of the techniques have focused basically on scleral fixation of the lens. Now, this was in 2014, Shin Yamane from Japan published their series of using, the flanged IOL fixation technique. And in the 35 eyes of 34 patients, they had very good results with minimal postoperative complications. And in fact, I had the opportunity to watch his video at the ASCRS where it won the grand prize. And it showed basically the technique. If you have heard the previous talk, it's almost quite similar, just that you externalize the haptic using a 27 gauge needle, which enters the globe tangentially intrasclerally 2 millimeter away from the limbus. And you introduce the 27 gauge needle and you kind of dock both the haptics. And then simultaneously, when you withdraw the needle, the haptics get externalized. And instead of tucking the haptic into the sclera, you use heat cautery to create bulbous end of the tip of the haptic called the flange. And this prevents the haptic from retracting back into the eye and thereby introducing stability. So this looked like a very minimally invasive technique where you don't have to open the conjunctiva, create any flaps, and looks quite elegant to perform. So if you see that in actual surgery, you will see that the three-piece lens has been introduced into the eye. Now they are introducing the 27 gauge needle. You can see it goes 2 millimeter away from the limbus. Again, it enters tangentially 2 millimeter into the sclera before going into the eye. And then you can see with the microforceps, one of the haptic has been introduced into the needle. Now you go and you catch the other trailing haptic, introduce into the second needle again into the shaft. And then as you withdraw both the needles simultaneously, you find that both the haptics get externalized. And then you just apply a little bit of heat cautery to create the flange. And once that is done, you can just tuck the haptics back into its position. And then the overlying conjunctiva can be mobilized. And that's pretty much what it looks like. This is where you need to go 2 millimeter behind the limbus and maybe about 2.5 millimeter away from that tangentially. And there are several instruments which help you mark these as well if you're a beginner. So let's look at, this is again a case of subluxated crystalline lens in a Marfan's, where there is extensive loss of zonules. So we decided to employ this technique. It's quite an old video. So you can see that we go ahead, we create a small rexis. We tried to see if we can salvage the back, but that was not possible. There was extreme subluxation. So we removed the crystalline lens bag, performed a nice anterior vitrectomy. Now we mark the 180-degree axis opposite each other, and we introduce the three-piece lens. Here I'm using a Sensor AR40E. It's important that you rest the leading haptic onto the iris, prevent it from going into the vitreous cavity. And again, the same thing, you go tangentially and then into the sclera. That's a 26 gauge needle. We did not have access to a 27 gauge needle at that point of time. Use good micro forceps. These are the MST ones, so they are nice. That's again very important in any of the techniques that have been described so far. It's good to have the right instrumentation. And I believe that if you want to do good secondary IOL fixation, you should invest in a good set of intraocular forceps, both the 23 and the 25. Unlike Yamane's technique, I modify in the sense that I don't go with the two needles simultaneously. You can see that I created I externalized one of the haptics. You do see a little bit of twist of the haptic, but don't manipulate too much. Use a micro forceps, grasp the haptic, introduce into the shaft of the needle. The pupil is very well dilated here, so you can really keep the needle peripherally. You don't bring it centrally. When you bring it centrally, that's when you have the problem that the haptic really gets bent. And now just use the low temperature, just use the cautery. Now don't need to touch the haptic, just stay away from it to get the flange, and then you tuck it in. And again, you can see that it's a well centered. After that, you can do a little bit of vitrectomy just to make sure that there is nothing that has come up, and make the pupil small. You can use some tricot to identify. This is just like a check before we close the case. And there is some viscoelastic, so we go ahead and wash it out. And put an air bubble, close the main wound, close the conjunctiva. This was a young patient, so we did not want to leave it sutureless. And that's how the patient was post-op. You can barely see the flanges. You can see a very nice, well-centered pupil. And if you see on high mag, you can see that there is no protrusion of the end. So that's how it should be. You should not make the flange so big that they are getting externalized or they are lifting up the conjunctiva. And if you do an anterior segment OCT of the haptics, that's how you can see that they are not subconjunctival, but they do look intrascleral when you do the scan and look at that. This is another case where the ACIOL is being removed, and we are going ahead with a secondary IOL implantation after that. Again, mark the axis, introduce the three-piece lens, 2 millimeter behind. Now I'm using here in this case, I'm using a 27 gauge needle, but you can see the pupil is not very well dilated. So whenever the pupil is not dilated, the amount of movement that you need to make with the haptics is much more than a well dilated pupil. And it's important before you start the case, whatever needle you are using in the IOL, always check that the haptic fits into the lumen of the needle. Otherwise, once you're inside the eye, so here you can see that to improve the visualization, I put a single iris hook. Thereby, my needle does not need to move too much centrally. I find this very useful of using a single iris hook to retract the iris so that when I go in with my haptic, I'm able to dock it in quite easily into the needle without having to move the second uh, end of the trailing haptic quite centrally before I introduce into the eye. Remember that these haptics are not very strong if you manipulate them too much. And if they bend, then you find that the final position of the optic is often not central, and you might even see a tilt or a rotisserie effect or a twist in the haptic. So I think it's important gentle handling of the haptics when you see. So this is a case where we remove the AC IOL, remove the deseg button, did the secondary IOL and a DMAC, and you can see 1 week later, the cornea looks clear, well-centered IOL. So what kind of IOLs do we use? Worldwide, people use the Zeiss CT Lucia 602, which has PVDF haptics. I like to use the Sensor 3-piece IOL, the AR40E. The other is the Freedom Sulco 3-piece hydrophobic IOL, which has PVDF haptics, unlike the Sensor, which does not have PVDF haptics. So the Freedom Sulco is a slightly better lens. Don't use the Alcon lenses because the square edge of the haptics, if your IOL is slightly anterior, it will rub against the iris and lead to pigment dispersion and secondary glaucoma. The needle that I use nowadays is the 30 gauge needle from TSK. They are 30 gauge externally, but the lumen is 27 gauge. So they are called the thin walled needle, and they are good because then you don't need to make very large flange. You just give a small flange and you find that that's good enough because the opening in the sclera is a 30 gauge, so that's quite small. But if you're using a 26 gauge or 27, then you need to make the flange a little bit larger so that it does not slip. The other thing that you need is a heat cautery. Your regular bipolar wouldn't work. So get a heat cautery. This is one that I have from Basco, which is where the cable can be, ETO sterilized. So you can always keep it sterile and use it. I think we have autoclaved it a few times. Nothing has happened to it. You have the Bowie cautery, which are also available. You can pick it up in Amazon as well. So these are the heat cautery that we use. And other than that, yes, you do need the micro instruments that we spoke about. You need an AC maintainer to keep or one of the trocars to have infusions, or the pressure in the eye is maintained whenever you are introducing the needle and you're manipulating the lens. Don't attempt this in a soft eye. Common problems, yes, as discussed earlier, haptic breakage, distortion, disengagement of the haptic from the optic if you manipulate too much. In between with the Zeiss CT Lucia, they had problem with the torsion at the haptic optic junction. So a surgeon does a perfect surgery and goes back post-op and finds that the IOL is tilted despite having. So again, I think they have attempted using the green laser to try and weld the optic haptic junction. That can be done, but I think best is to exchange. If you pull on the haptics too much, or if your initial entry point is a little bit anterior, or if the patient has a deep anterior chamber, so don't always keep 2 millimeter as the standard. Always go back and see the anterior chamber depth, and you can go 2.5. So if your entry point is too anterior, then the IOL gets lifted up, and then when you dilate the pupil for fundus examination, sometimes patient may come back with a cat's eye pupil or optic capture. And again, same thing, if you make a very large flange, sometimes you will have the haptic protruding from the conjunctiva, like from the sclera, causing irritation. This is again a later paper of 100 eyes of 97 patients, again by Shinya Mani. And you can see that even in this consecutive cases, they did not have any significant problems besides having optic capture, maybe a vitreous hemorrhage in 5%, which is again self-limiting. Sometimes you may get cystoid macular edema, which happens with any scleral fixation IOL technique. And that's why I think complete anterior vitrectomy is very essential. So you don't have any traction on the vitreous leading to persistent macular edema. So in conclusion, I think the Yamane technique of flanged haptic intrascleral haptic fixation can be applied to securely fixate the IOL in the absence of capsular support. I like it because it's minimally invasive, provides a stable, secure, well-positioned IOL with good visual outcome. Does have a learning curve, but once you become comfortable with it, I think this can be done very well. Thank you. Thank you for the patient hearing.
Thank you so much, Dr. Rajesh, sir. That was amazing presentation. And truly speaking, you made it so simple that it looks like that anybody can do it very comfortably. But that was quite a good one. And the best part was you explained why not to use Alcon lenses, because just now I had a question that can we use Alcon multi-piece. So you already explained that. Dr. Srinivas, your
Rajesh sir,
comments?
presentation, and always treat to watch your videos, not just corneal surgeries, but also the SFIOL surgeries. So the few points, sir, because Indians are not known as jugaad people, the people who actually invent it, and Indians make more and more jugaad of it. Uh, the one thing for the trailing haptic, which few of the authors are now doing, is surgeons, is to bring the needle outside through the tunnel
Yes,
and then
I
touch
I
it.
do have some videos of that, but the problem is that just like what Minu had shown, that if you don't know where to grasp the haptic, when
Uh,
you bring your needle out, the amount of movement of the trailing haptic is quite a bit. And at occasions, you have kinked the haptic when you're trying to put it. So once the haptic gets kinked and you externalize it, you will find that you may lose out on the centration of the optic. Then you find that you have a tilt and then you go on manipulating. So I think when we are doing a program like this, I think we should. So I think, yes, you can externalize your second needle through the main wound, and then you can use a regular forceps to put in the
so-
haptic.
And
Yeah.
the second thing is, I agree with your point that the 30 gauge thin bore needles, I think they are the best, because there is a possibility where I initially used to do with a 26 gauge needle with a small amount of flange, it used to come
Flip.
out and
Yeah.
then again bring it back, and again that will cause haptic manipulation. So again, disfigurement of the haptic again will lead to a lot of these things. So the third point is the Bowie cautery. I don't know, please correct me. They have stopped giving that small edge. What is there? Now they have a neurosurgical operative. That's what they told me, the Basco people.
Buy it from Basco. Basco still has it. The
I
the
tried with
the
Basco,
the
sir. They
the
said
one
that
with
they
the
have
console, it's a Chennai-based company. If you go Google it, you will
Chennai-based
find Basco. They have a
Basco
thermal
cautery.
cautery, and Basco, if you put in Google, it will show you. The
I
console and the cable which is there, that costs only about 4,000 rupees. They have a battery operated unit as well that costs only about, I think, about 1,500 rupees.
When did you
And
take this tip, sir? Last.
these are available. I just bought additional tip just maybe a few months back. It's all available.
So when I asked them 6 months back, they said that they have stopped out. But anyway, I can definitely ask
You
to
will
do.
find it in their category. You will find it in dermatology. You will not find it in ophthalmology.
Correct.
You go.
Okay.
Correct. So the other alternative, if people do not have the Basco pottery, is to use a continuous waveform of laser. Of
Mhm.
course, it's in the Vitruvitina setup. If you have it, then use a continuous waveform. It shrinks very nicely.
Yeah. People
Uh,
also use a ball cautery. They use a
yeah,
muscle hook or something. They
Yeah.
heat it over a flame
it
In,
causes a
and they
in
just
fact,
bring it, and
ball
that create.
cautery is quite commonly available also, because previously it was used. And in fact, during our residency days, we have seen it being used, the ball cautery.
no,
So
no.
I was
I'll
just good. Yeah.
advantage of that ball cautery is because it's a round configuration. Whenever you touch that, the haptic, the flange, what you make also becomes like a U shaped, like a shape like this. It
You don't need to
form
touch.
a
You just
real
need to
one.
bring it close to the haptic, and the haptic will start. So I think we should not be touching the haptic with
Yeah, you
the.
should be touching it.
Okay.
Yeah, that is
Just the heat can make it nicely.
Yes.
exactly.
See, whenever you want to do any technique, you want it to be repeatable. So when you
Yeah.
use muscle hook or ball cautery, you cannot have consistency every time because there is variation in temperature. So I think it's important that you invest and find one of these heat cautery. They are easily available. Even on Amazon, if you go and see,
Amazon. Yeah, that's what I was about to tell you.
people have
Amazon you
bought on
search, you'll get.
Amazon, and you can. But Basco makes it, so I've been buying from them, and cables get spoiled after some time because of repeated sterilization. So we procure new ones, cost only 800,000 rupees. So these are good ones. You can definitely use.
Sir, I just wanted to clarify one or two things. The
Yes.
important point about the needle. See, I was also there when he presented it first, and they were even in the publication. It's a 30 gauge large bore needle. That is what they say. We don't have the
We
30.
don't have it. I got it from the
We
US.
don't have. But what you showed was how is it? Please tell us, sir. What is the outer size and what is the which one do you use? Inner bore bigger or?
No, the thin wall needle is a 30 gauge needle, but what they have done is they have made the wall of the needle thin. So the inner bore is 27 gauge.
Yeah,
So
yeah,
if you
that's
take a regular 30 gauge, it will not fit. So if you take this, so what I do is, because I know variations in manufacturing can be there, so I always, before I start surgery, I take the IOL and I just check that the haptic is fitting into the bore. Because once I introduce the needle and my IOL is inside the eye, then if it is not fitting, then it's kind of a problem. So I think it's important that we check. And I would recommend that the Yamane technique, if you have a model eye, which you use for phaco practice, you can get some of these lenses, the freedom lenses, which are not very expensive. And in the wet lab, you can just practice using a 26 gauge needle, the mechanics of it, how you dock and how you do that. Because once you do it outside in the wet lab, in the patient's eye, you will find that it's comfortable. Otherwise, sometimes you straight away go and try to do in the patient's eye and you're not familiar. You suddenly feel you have two left hands, you have all kind of movements.
Yeah.
Sir, what did you finally to order? What is the needle name you order at? 27 with.
It is
Board needle. It's
no,
available.
it is called TSK.
Ah,
TSK 30 gauge needle. It's called thin wall needle.
Yeah.
Okay.
and one more thing, sir. The trailing
One
haptic.
Mumbai.
Yes, sir.
Who gives it? It's available in Mumbai also.
Okay.
Okay. So the trailing haptic, there was one modification which I heard somebody presenting that they introduced the second haptic first into the needle.
Yes. So
First,
Brian
yeah.
Kim, I think no, Terry Kim, I think he showed that what he does, he makes an inferior paracentesis at 6 o'clock. So he takes out the leading haptic through that paracentesis and puts in one of those silicon, what you do on the haptic so that it doesn't slip back. And then he goes and puts the trailing haptic first and then puts the haptic back into the AC and then because for a right-handed person, that's relatively easier to put than the trailing haptic. So that also can be done.
The question to Shin Yamane at that time was when one haptic was in the needle and he used two hands. One is for the needle there and the second is for the trailing haptic.
Mhm.
Was who's holding the other needle? But he said that is left free. He's
Because
left free.
what happens is, as long as the haptic is inside the needle, your needle tip will not go and touch the retina.
Yeah. So
Because the haptic is holding the tip. We are worried about that, that if you leave the needle free, what will happen? But as the haptic is engaged in the tip, it will not allow free excursion of the tip of the needle. So it will not go and touch anywhere. So you can do that. My problem is because we put the needle onto a syringe when we are introducing. Once you do that, then you have to disengage the needle from the syringe and keep it there. So for that also, there are some sets which have come, where it's like a clip at the tip for that needle, So you just press it, you can release it, you can leave the haptics there for Yamane technique. But I
So,
guess if we
Yeah.
understand the principle behind it, we can use it. Any of these techniques, I guess all of them work equally well, whether you use the blue diol or the flange T or.
So this is a question that how many millimeter were you away from the limbus and the mark which you have made, the entry of the needle?
It's important to have the haptics 180-degree opposite from each other. Sometimes we use that visibly. That's not a great idea. So always use a toric marker and mark that. I go 2 millimeter behind the limbus, but depending on the depth of the AC, I can go a little posterior as well, because otherwise when you're going that, you will engage the iris,
Right.
And you start to create that tangential entry. You are about 2.5 millimeter away from the entry point.
From the entry point.
But the globe should be firm when you're putting the needle. If your globe is soft, then you will find it difficult to go tangential. You will enter into the eye much faster.
Yeah. So for that, we are already using AC maintainer.
AC maintainer, yes.
I think that was an amazing presentation and wonderful discussion.
So one last thing, sorry.
Yes.
The flange which Yamane told was to be tucked back into the scleral pillar.
Yes.
So many people think, or I've seen, that it is just under the conjunctiva means
Yeah,
leave it.
no,
So
because
has to go. Yes.
people are scared that it will go back into the eye, or their track is too wide. So I think it's important. That's why I showed you the ASOCT. In that you can see it's flush in the conjunctiva, and you can see that's why it's called intrascleral. So the tip. So it shouldn't be. That's why you don't make a very large. If you make a very large flange, you can't really tuck it in. And then later on with the movement, it starts. If your track is a little loose, let's say you use a 26 gauge needle, then it's not holding on to the haptic. So then the haptic moves, and you find that the flange kind of protrudes through the conjunctiva, and every time you're on slit lamp, you try to push it back. So I think this is where
The only thing is, if you really want to practice it for the beginners, then always you can do with a flap. Make a
Yes.
flap, small flap, or the Hoffman's pocket, whatever it is, where
Correct.
it is not exposed. So in those cases, initially you can just try doing that unless you get a beautiful flange, because getting a good flange is the reproducibility of that is not very easy. With each case, with case on case, you don't know, they don't have a guide how much to go in. Sometimes it goes very fast. So you always have to hold a forceps in the left hand. And sometimes when you touch it, it takes the shape of the forceps. It becomes like a T shape again. So then you cannot tuck it back inside. So maintaining that bulbous portion is very
tip I would
important.
like to give is, first of all, keep your field dry. If it is wet, then you will find that you bring the heat, but because of the fluid around it, you're not getting the flange.
Exactly.
Keep it dry and keep it away, and you bring it slowly closer till you start seeing the changes. So don't be in a hurry to touch if you touch, it makes all kind of disfigurement. But if you stay away from it and just bring it close till you see the end swelling, and just because what do you need? You need the flange just to be larger than the shaft of the haptic. That's sufficient to prevent it from going into the air.
I have heard another expert telling the way she maintains the size always. That is, you make the tip the maximum hot, and then go
Just
near
touch
it.
it.
So just before touching it, stay there 1, 2, 3, and come back. That's it. And repeatedly do the same thing.
Practice in the wet lab. Just take a
Practice in the lab.
6-0
Near it,
prolene.
1, 2, 3, come back. Then it
Just
will
take a
create the
6-0
same size
prolene in the
flange
wet
always.
lab, and take a cautery and keep cutting the tips and practice
Zero
the
prolene
perfect
and the
flange.
haptic doesn't behave the same way. I have seen that.
You pull out haptics from a rigid IOL. Rigid IOL is 100 rupees.
Yeah.
Pull out
So that you
from
can
that,
do,
and you
because
price it on that.
6-prolene, it goes very fast. I've seen that because we do it for Sergio Canabrava technique, where we use the 6 and the 5. It goes super fast, like that it goes.
No, but
With the haptic, it takes time. Yeah.
So it is probably just like that, the way we practice on the goat's eye initially and then move on to human eye. There is a lot of change.
Correct.
But then practicing in wet lab can be a good option.
It gives you that level of comfort,
confidence,
when you're doing in the
and
patient's
confidence
eye.
also.
Otherwise,
Yeah.
what happens is, I have seen somebody was showing me a video. He cauterized it. He kept on cauterizing, said that it shortened the haptic.
Oh, yeah.
Because you kept on, because the flange keeps forming, you keep going, and then you find that you have
There's no guide.
asymmetric haptics.
Yes.
And one side your haptic has become shorter, and that will pull the optic to one side.
Right. So thank you so much, Dr. Rajesh sir. It was indeed a wonderful presentation and amazing discussion.
It's a nice discussion, a lot of different techniques, learning everything, small points.
So do we have the Dr. Renuka with us?
Yes, ma'am. I'm there.
Okay, wonderful.
Okay.
So now we have the last presentation of today's evening. Dr. Renuka is here. She is consultant cornea and refractive surgeon from Joshi Eye Institute. She is a wonderful academician, a prolific surgeon, and she will be talking about another good technique which is quite commonly practiced these days, the iris claw lens. Dr. Renuka, your presentation, please.
Yes. I'll share my PPT, ma'am.
Okay.
Dr. Renuka, can you also connect your camera, please?
Yes, it's connected, but I'm unable to. You need to enable it. Uh, am I visible now?
No, doctor, it is switched off from your end. There is a camera icon. You need to enable it, please.
Yeah,
Or
yeah, that's what
you can try screen sharing at least.
I think I need to be made as. Yeah.
Oh, no, there is no restriction whatsoever.
Okay, got it.
So you can share your presentation, Dr.
Yeah.
Renuka.
Did you join from browser, Dr. Renuka?
No, sir. Like I got a link and I joined from that. I'm
Um,
browser. I've joined from browser. Yes, yes.
no, please just log off and join with the application. Don't select browser.
Okay, okay,
You can
okay.
just log off and log in, please.
Okay, yes, yes.
Srinivas is there. Well, she's coming on. Let's make it active. Srinivas, well, what is your opinion on having pars plana vitrectomy in all these cases of scleral fixation?
Sir, ideally not required in most of these cases where unless there is a, especially where there is a PVD or associated with vitreous hemorrhage, or you see that there is a kind of break where you need to do that, or there is a focal retinal detachment. In those cases, we usually do a vitrectomy. But otherwise, just a little bit of anterior vitrectomy is good enough. But the only thing I tell people, anything we are doing with these scleral fixated IOLs, especially with the 9 or 6 or the bag has to be eaten off. See what happens, the bag usually fibroses and that comes in the way sometimes. If the lens is not very hard, especially when it is being hooked, as in case of Sergio Canabrava technique, or in case of when we use a 9 or 10 proline sutures, there is a kind of tilt or decentration happening. So the bag has to be taken out when you know that the lens cannot be fit on the bag or there is no sulcus, anything, then only we go in for this kind of technique. So it has to be removed. So just doing a good anterior vitrectomy, I think is good enough. No need to do a complete vitrectomy because if you go in again, sometimes you might have to induce PVD. Younger the patients, more difficult inducing the PVD and all those things. So just doing an anterior vitrectomy, getting a good area in the anterior part of the pars plana, I think is good enough, sir.
Has the speaker joined in? Uh,
No, doctor.
In your experience, no, if you have larger white to white, if you have a 12.5 white to white, then which IOL will you choose and which route would you choose?
Sir, the wider thing, I think the best would be to go in for which technique I'm telling you is best to go in for the Sergio Canabrava technique because there you can titrate it. See what happens with Yamane, there is no guide. So you have to go in, keep doing it similar on other both the sides. Reproducibility might be a little challenge because there is no marking on the lens. Like how much you need to do. If you take 2 mm, how much you need to do. If you take 1.5 mm, how much depth or how much deep you need to go. But in case of this Sergio Canabrava, it acts like a dumbbell shaped. So the both the sides you hook it and then keep one. It goes and sticks into the pars plana or the pars placata area, and then on the other side. So you have a big suture there, the proline suture, where you can use it like a guide. You can go more deep or a little less. If you're little less, you can still go more deeper. So the wider the thing, then I usually go in for the Sergio Canabrava technique or the modification of that Canabrava technique.
Which IOL you use for the Canberra technique?
The same, the sclera fixated with the eyelet, the two eyelet fixation. But in case if it is to now we have started using the Acreos IOL using the four flange. That we see the haptic stabilization is also very good. The four eyelets of the Acreos IOL and using it like a Gore-Tex, or even you can use a 6-O-Prolene and make it a double shaped on all the four flanks. So the idea is the stability of the lens is much better. The 4-point fixation usually holds much better as compared to any of these 2-point fixation. Like how we are comparing with the CMT flex versus the 2-point fixation done by the 9O Prolene or this thing. The same we are trying to do with the 4-point fixation also. And now it is showing that the good stability with lesser amount of tilt, hence lesser astigmatism.
Yeah, so this 4-point I have also done for some of the cases. So the 4-point means your 6-0 proline goes into the eye, goes through one of the eyelid, comes out through the other eyelid, and then exits the eye. So it's like at the four corners of the eye. If you were to draw a square around the circle or around the cornea, at the end of the each square, you will have one of the end of the haptic coming out. So you have a suture going in, coming out, suture going in, coming out.
No, sir, I'm talking about the four eyelets of the IOL.
Yeah, that's what I'm saying. Four eyelets means the
Four eyelets, correct.
four. Yeah, so
Four
you
eyelets.
basically you can pass this. I have a video that I can share. I think I must have uploaded it on YouTube. So you can basically introduce a suture through one scleral opening, goes through both the haptics one by one, and then exits at the other end. So you just have two flanges at the two end, but it holds two points.
Can I show that, sir, if you don't mind?
Sure. Why not?
Yeah, I'll just show that. So
Has
this
Dr.
is
Renuka joined?
not yet.
Not yet.
Show that presentation.
Not yet, doctor.
Okay.
So this is sorry. This is what I was sorry. Is it seen?
Yeah.
This is the goal I was talking Fogla, sir. This is the Acreos 4-point fixation.
Yes. The same
So bring
video
it to
even I
that.
have uploaded.
Yeah.
I'll share a
The
link.
same way, bring it, make it, take it one and thread it into the second. So once we do that, cut the both ends and take a 4 millimeter gap, and either you can use a 23 gauge or a 25 gauge trocar and make a stab entry and then introduce it one by one. It might look a little messier because of these threads lying around, but definitely once you know that where the thread ends are, and then pull it and fix it. So remove both the ends and just tie it. So this is tied at the one side. Pull it and then tie it at the second end. And then just glue it off. So with this, I think it has a real good most of these things. Sorry. The tilt is really less with these kind, but the only thing is the suture knot has to be little buried. Or you can use, some people say use the Hoffman pocket because they have seen the conjunctival erosion even after using the Gore-Tex suture also, which is also not good. And these are the kind of direct entry of the nidus for the infection to go inside into the vitreous cavity. So either you can use a Hoffman pocket and do it, or make sure that the conjunctiva is tightly covered over and the suture buried inside of the Gore-Tex.
So I think Dr. Renuka is not able to join.
Okay.
So so we can have a few words about iris law lenses which are being used these days. Any of you would like to say about it? Any comment?
I think I can, if you don't mind, I have that presentation ready. Recently did it in Apau, so it's a very fresh. You know, if the speakers allow it, then I can
Yeah,
show it just quickly. Just it's a less than a minute video.
yeah. I think then you can
Don't
go
make it
ahead.
less than a minute. Yeah.
Okay, one second.
So
Yeah,
I think the
I think you
problem with
can. Yeah, here it is, and
yeah.
sorry. Yes. So I think it's worst describe the iris claw and the artisan lens. I'm just trying a video of that. So here, just make a two stab entries on both the sides, and this is what I was mentioning. This was the bag which was there. We had to eat up, and always check whether it's holding up well. Otherwise, sometimes after going inside, we might see that it is broken, and again we have to disenclave it. So here, just position it exactly 90 degrees, and then use a blunt forceps. That is most important, or a dialer or anything. It's not use a sharp one because it might pierce the iris and cause a iris hole. So one side is stuck. Similarly, take it to the other side, centralize it, keep it well, and then just tuck it up. So sometimes you might see a temporary peaking like this, but usually it goes away. So it's usually in the initial part, and after certain part, it usually. So I think this was just I wanted the advantages is just definitely the quicker visual recovery, better visual outcomes, fewer complications like less corneal and endothelial cell loss, less astigmatism compared to the other secondary, but not recommended in the patients with pathological mydriasis or extensive iris defects and ischemic vitreoretinal condition, especially with the uveitis, whether it's a non-infectious uveitis, because it always keeps rubbing the iris, and the chafing of these pigments keep happening, and that might incite the inflammation more. So we usually don't put it in pediatric cases or in cases which has the inflammatory eye, or in cases where they need you expect that the highly pathological myopia they might have in retinal detachment cases. So in these cases, putting the silicone oil or the gas, so it's always troublesome because the oil or gas might come into the AC anytime. So, to be very frankly speaking, I do not encourage this technique. It's my disclosure, but definitely it's a good initial to try it. And then once you get an expertise over the other kind of sutureless SFILs, you can always shift over to it. Thank you.
Thank you so much. That
I
was
think uh,
a quick
one.
one, but wonderful one. The only thing which I have realized it that during long term there is a iris chafing at that particular area, and that iris atrophy might lead to dislocation of the lens.
Exactly.
And then re-enclaving those lenses are extremely difficult. Then you have to take it out and then put some other lenses. So, but they are quite easier to put, and that is why they have become so popular, because they are available and easier to put and very quick to be inserted. And that point is also very valid that we should use some blunt instrument, because even with blunt instrument, sometimes they pierce a whole kind of thing if the iris is quite friable.
I
So
think Dr. Renuka has joined, madam. Dr. Renuka, are you there?
No, sir, she hasn't joined back.
She has not joined. Okay, fine. Yes,
How about
continue.
the
One
how about the
important
need?
one important point
I'm
that I
unable
wanted to
to
make.
share, so I'll just be telling. Can you hear me, sir?
yeah.
Yes.
Okay, so I'll be just sharing the video because I'm unable to uh, uh, open it in another laptop because the video is heavy thing. So I'll be just sharing just telling the video, making it short for the viewers, and just the 10 mantras to have a good iris claw fixation.
Okay, fine.
You're able to share the screen, Dr. Renuka? No.
Yes, sir. Yes, sir. But the thing is, I opened it in my old laptop because it's not supporting. So I'll just
Go ahead. Quickly, you can go ahead.
okay.
Just now we saw your camera. Yeah, your camera's on.
Yeah. We can see you now. Dr.
Okay.
Renuka, we can
Can
see
you?
you now.
Is my PPT available? Okay.
No,
Am I
You
PPT
have
is
able
to
to
share it.
share my?
Share.
but you are visible now.
Can,
Please share.
The video should play. So, no, only the video. I'll be playing the video. The video is not playing in this file.
No, the whole presentation has come on. Why don't you go full screen?
No, I need to edit it in the. Sorry for all these things. I literally didn't think.
Doctor, can you stop the share for a minute, please?
Yes.
Dr. Renuka, can you just stop the share?
Yeah. Oops.
I have stopped it. Just
Yeah.
click on the share button once.
Yeah.
Don't go sharing. Just click on the share button once.
Yes. Wait, I'll turn only the video.
You're audible. Can
That's what I need to open the video.
just click on the share button once. On the left hand side, you have entire screen option. Just click
Yes,
on it.
yes. One
and
second,
then
sir.
share.
1 second, sir. Where is this person? The video. Where is my this attached?
Just click on the screen share button once. When
Yes,
the
sir,
pop-up
yes.
comes, just select the entire screen option and then go sharing.
You open it. You open it.
Yes.
Share.
Share.
Screen.
Screen.
Interesting.
It should be here. Okay, so
Just click on the presentation, please.
yes, sir, yes.
Just make it full screen also, please. Thank you. Is there any audio in it?
No. My voice over just.
Okay, just make it full screen, please.
Okay, bad luck because in my old laptop also the file is not supported. So, okay. So I'll just go with the tips. So as sir showed a beautiful video, so I'll just tell 10 mantras for the student.
Can
So
you
all
just
the students over
stop
here.
share or select the right
Okay,
PPT? Your entire file folder is visible.
Yes. So thank you, but I am doing a very bad job here. So lack of technical support at home. So I'll just tell briefly 10 mantras, which I tell my students. So number one is, you should know the surgeon who is implanting should practice the steps already in the mind. So when you're ready and you know how the iris claw works, then you can tuck it in a way with no you can make a cat eye free pupil also when you know the exact technique. So when I want to tell only the best things, I would tell 10 mantras to my students. So if first mantra would be having to know what is the size of the iris claw. Now in the market, we have foldable iris claw also, which you can implant to 3.2 incision. But what is available at every institute is the rigid PMMA ones. Okay, we at our institute have iris claw from Excellence brand by Madhu Surgicals. So which is having a 5.5 optic. So for that, I need a tunnel. And superior tunnel gives the best technique and place for insertion. Next is side ports. So you should make sure that they are 90 degrees away. So best is to have it at 3 and 9 o'clock. And before inserting the only thing for a surgeon to check is check the patency of the enclavers, whether there is an opening. So you need to check it with a dialer and see whether the enclavers are working, because once you go inside and you have not checked it, because I have times experienced myself where it breaks or there is no opening, it's not patent. So when this happens, then when it's inside the iris and below the iris where there is no view, so it's a blind procedure where you're enclavating it by placing it posterior to the iris. So next step is when you, after checking, how you insert it. When you insert it superiorly and positioning it above the iris before insertion is very important. It should be horizontally placed where the enclavers are at 3 and 9 o'clock. Then go with your dialers. Okay. How to, if you're a right-handed surgeon and you want to enclave the right first, so you can, another thing is you need to have in hand is iris claw forceps. Because as sir said, India is full of jugaad. Some people try to enclave it with the McPherson's, but mind you, McPherson's will have a torque with it. So with the torque, the IOL rotating, you might the IOL might slip away and you might not get the exact positioning, and there might be tilts. I have iris distortion, improper enclavation. So what you can do is have a iris claw forceps handy prior before. So this should be in the checklist that the forceps should be available. The power which you're inserting in the eye when it's an emergency situation and you need to decide it on table, you can take like 0.5 diopters less than in the bag for sulcus and 1 diopter less if you're doing an iris fixator. So this check the enclavers, insert it, position it, tucking the right, then comes tucking the left. So when you're tucking the left side, you need to hold the forceps, push the iris, make sure you take the tissue. Mid peripheral tuck is very important. If you take the tissue around the pupil, you might make a pupillary distortion. So mid peripheral tucking, good iris tissue, and behind the collarettes is important. So after this, one last thing mantra is making a PI. No surgeon should come out without making a PI. And mind you, most of the anterior segment surgeons and the beginners who are into inserting their first iris claw don't know what is this vitrectomy, or I mean settings you need to put on a vitrectomy machine for a iris peripheral iridotomy. So you have to lower your cut rates. You cannot use a 3000, 5000 cut rate where you're doing the anterior vitrectomy in those cut rates, and use a similar one to make a peripheral iridotomy. So make sure your the settings are as low as below 300.
So that were wonderful tips by Dr. Renuka, and the video was already shown by Dr. Srinivas. So I think that completes the whole of the talk. And any comment, Dr. Meenu? You are muted.
Yeah. So make sure you enclave it with a good tissue. And so these are the 10 mantras. First of all, the mantra not to be missed is checking the patency. Next is the positioning. And next is do not forget to come without making a PI. So PI is mandatory. I'm sorry, I'm unable to share
No
my
problem. No problem, Dr. Renuka. Those were wonderful tips, and video has already been shown by
I think
Dr.
sir
Srinivas,
has
so
covered me up
need not
very well. Thank you, Srinivas sir.
Yeah. Welcome, Renuka. Yeah.
So in that way, we already completed this wonderful webinar on variety of options which are available. And I'm pretty sure the viewers, they would love to see this amazing surgeries and wonderful discussion. Dr. Meenu, would you like to add something to this?
No, nothing. I felt always that I don't do this iris claw, but then I felt always that the paracentesis which you make has to go limbal, so that you can go parallel to the iris as much as possible, close to that, so that you can go
Yeah.
straight and enclave, rather than
Mhm.
going from top and then coming down and trying to enclave. Otherwise, doing a
Yeah,
PI
it's
and a
like
good
a stab
vitrectomy,
entry,
anterior
boss.
vitrectomy. Pardon
Yeah,
me?
And
stab entry into the limbus.
Stab entry,
yeah,
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 Yeah.
and
stab
also
entry.
a good anterior vitrectomy and a PA.
And
And a
one must buy the iris forceps that holds the IOL very snugly, and therefore prevents the slippage of the IOL. So I think that is a wonderful technique.
She said there
But
is a foldable one. I don't know where it comes from. Have you seen that?
Artiflex is the company, sir, which gives foldable, and it's not available freely in India. I suppose, we see a lot of foreign ophthalmologists who use Artiflex, which you can insert it through the clear corneal incisions. Plus, you have a repositor. I mean, you need to have an inserter for that. How you have injectors, so you have the inserters. So only the optic is the one which is folding here. So the haptics are engaged and the optic is folding, and you just inject it. The optic folds and unfolds in the AC. And you need to take out your repository, I mean the inserter. And after that, it's same as that of the PMMA.
Thank
It's
you
just
so
that the
much,
optics fold.
Dr.
So
Renuka. That is
Artiflex is the one which, the company which quotes foldable iris claw.
so that is a wonderful information. And for the viewers, I would like to say that all the questionnaires, they will be live from tomorrow on the module. So you can attempt those questions and win the prizes also. And with this, we have come to end of this webinar. And Dr. Harshal has joined us.
Yeah. Thank you so much, Dr. Shalini, for moderating this webinar and taking so much care. Thank you so much. Thanks
pleasure,
to
sir.
our speakers, star speakers, Dr. Meenu Mathin, Dr. Divakant Mishra, and Dr. Srinivas Joshi, who joined as expert panel and gave his amazing insights into the topic, Dr. Renuka, and all the speakers and expert panelists for this. Thank you so much. And this Saturday, we'll all join for yet another interesting topic, phaco in uveitic cataract. So we'll be having Dr. Mamta Agrawal, Dr. Ekta Rishi from USA, and Varin Shankar Nethalya joining for this very important topic. Thank you very much, Dr.
Thank
Minu.
you, everyone.
Rishi.
Thank you all.
Thank you
the
so much,
wonderful
Dr.
speakers.
Shiva. Thank you, Dr. Shalini.
Harshal Bhai.
Thank you.
Thank you,
Thank
Minu,
you.
Minu sir.
Yeah.
Thank you, Shalini madam. Thank you,
Thank
Renuka.
you.
Wonderful
Dr.
Thank
tips.
you.
Renuka,
All the
thanks.
best.
Good night,
Yeah.
everyone.
Thank you.
Thanks
Good
a
night,
lot.
everyone.
Good night.
Thank
Good
you.
night.
Thank you.
Bye.
Good night.
Bye.